speakers. Our first speaker is Dr. Grace Ma, who's the Associate Dean for Health Disparities, Founding Director of Center for Asian Health, and is professor at the Lewis Katz School of Medicine, Temple University. Dr. Ma is going to present to us on Break the Silence using an integrated approach to eliminating hepatitis-related liver disease disparities among Asian Americans. Dr. Ma, please take it away.
Thank you. Good afternoon. I would like to sincerely thank Dr. Rina Das and the Planning Committee for your invitation. Thank you for the opportunity. So my presentation is going to focus on primarily on breaking the silence and using integrated approach to eliminating hepatitis-related liver disease among Asian Americans. Next slide, yeah. And as we know that liver cancer incidence, it has fastest increase than any other cancer in the United States. Next slide. So in terms of the major preventive risk factors, actually hepatitis is the major risk factor for 65% of the liver cancer related disease. And there are also other risk factors related to obesity, alcohol, fatty liver. So these are really preventable risk factors. Next slide. I want to just talk about the racial ethnic disparities in mortality rates, specifically for hepatitis B, chronic liver disease in the US. And I wanted to focus on the chart on the D. And you can see with the green line on the D graph, that represents Asian Americans who have hepatitis B related liver disease. It's 3 times higher than other ethnic groups. And the red line is African American, the blue is white, and the purple is Latino population. Next slide, please. So how common is hepatitis B in the US? We have about 2.2 million people are infected with the hepatitis B. And unfortunately, the majority of them have not been diagnosed. Only 1/3, 33% of these people infected were diagnosed. So there's really a lot of efforts needs to put out into for increasing testing and the linkage to care. So majority of these people who are infected with Hep B are foreign born, either from Asia or Africa. Next slide. So as I mentioned, API have the highest prevalence rates of hepatitis B infection than any other racial ethnic groups in the US. And API represent about 6% of US population, but they represent about 58% of all persons living with hepatitis B. So this is a huge disparities that needs to be addressed. Next slide, please. So I'm just give a map of Philadelphia and New York City, where the concentrations of hepatitis B infected people that were highly concentrated by Asian and African immigrants in the southwest of Philadelphia and northeast and central Philadelphia, and also in different boroughs where have a darker blue maps where the hepatitis B infected people are concentrated geographically by this area. Thank you. Next slide. So the next few slides, I wanted to focus on some of the NIH-funded research projects that we had addressing liver disease and cancer disparities at the Center for Asian Health, Temple Lewis Katz School of Medicine. Next slide. Our research has focused on this continuum of interventions for liver disease prevention and management from primary, secondary prevention to patient-centered care for hepatitis B patients. We had R1 cluster randomized trials using multi-level intervention or community-based intervention specifically to increase Hep B screening, vaccination, and then we moved into the patient-focused PCORI-funded projects, specifically navigating the patients for follow-up care and to prevent liver disease and liver cancer. Next slide. Here's one of those cluster randomized trials and results. On the left map, you'll see all the patients and participants that we have worked in these zip codes and neighborhoods, a very low screening rate. And post our intervention, where you see the dark blue of those participants in these zip codes have participated in screening. These are specifically focused on the Vietnamese and the Korean Americans. Next slide. So I want to talk a little bit about the intervention approaches that we have used. And we adopted multi-level intervention to address the multi-level disparities among this population. At the individual level, we have used culturally, linguistically appropriate interventions to educate the patients and participants and navigate them throughout the health system, trying to reduce the barriers. In addition, we also work with healthcare providers, trying to adopt some flexible policies and schedules to accommodate, to provide more linguistically and appropriate services, culturally appropriate services, as well as training the patient, training the clinical staff, and with more sensitivity related to the population needs. We also have engaged our community leaders in every step of our program planning, evaluation, as well as dissemination. Next slide, please. So here are the major area that we addressed in our intervention, specifically related to access to care. And many of the Asian populations that are lack of health insurance. Health insurance can be one of the major factors for screening and the linkage to care, as well as the culturally, linguistically appropriate services available to the staff, to the participants and the patients. Oftentimes we have observed there's a lack of recommendation from healthcare providers. So we provide the physician education and to these physicians and clinical staff who serve the population. We also trying to address the low socioeconomic status and misinformation about Hep B transmission. And specifically, we're trying to negotiate with federal qualified health centers and clinics to see how we can reduce the price for testing and the screening for these participants. And we also trying to educate them related to the discrimination matters. And so these are all at multiple levels. Next slide, please. Again, this is one of the studies, as I mentioned earlier, and we used a multi-level approach. As a result, we're able to observe a high screening rate, about 88% among the Vietnamese American populations. Next slide. So this is one of the studies that was originally funded by MMHD using community-based participatory approach to enhancing hepatitis B screening and vaccination for underserved Korean Americans. We specifically worked with faith community and working with the 32 Korean churches randomized into intervention control group. And we had multiple measures at baseline, post 6 months and 12 months assessments. Our primary outcome is behavior change on Hep B screening and vaccination. We also target to change the knowledge and attitudes, not only at the individual level, but also community leaders. Next slide, please. So this is the results of this study. We are able to observe high screening rates among these participants In the intervention group, about 92%. And we also have identified those who need vaccination. Next slide. With this multi-level and community-based participatory approach, we have developed robust intervention, evidence-based intervention strategies. So we're able to achieve a high vaccination rate as a first shot, about 92%, second shot, 90%. And with the third vaccination shots received about 84%. So we have learned a lot through this process. Actually, right now, we're using this model and trying to help with the COVID-19 vaccination. We have developed some very robust patient navigation strategies, more culturally, linguistically appropriate, and working with community leaders and partners, faith leaders at every step to set up mobile clinics and also navigating these community members into the vaccination. Next slide, please. This is a study specifically focused on hepatitis B patients. As we know, the adherence rate for monitoring and the treatment medication is extremely low because oftentimes when they do not have symptoms, it's not their priority to go to see doctors. So we also developed these strategies, whether it's in-person or virtual patient navigation, text message, mobile intervention to help these patients to get regular screening and follow-up testing. As a guideline, it does require Hep B patients to follow up with their physicians every 6 months because there is no cure for hepatitis B. And we are able to bring up the follow-up rate as about 77% for the intervention group at 6 months follow-up. And at 12 months, we're able to observe about 90% adherence. And in terms of liver function testing and other related screening and testing for this population, we also have received and observed significant increase for the patients at 6 months, about 52%, and at 12 months, about 75%. Next slide, please. And next a few slides, I wanted quickly to share of some of the community outreach and the engagement activity and with the African-American, Asian, and the Latino population. This is out of our U54 partnership at Temple University Fox Chase Cancer Center and Hunter College, funded by NCI. We're in our third year. One of the components is our outreach core is targeting a number of cancer sites, so the liver cancer specifically related to the hepatitis and other risk factors. So we have engaged the community, actually, and Ada is one of our community partners, and you're going to hear more from her. And we worked with community partners, educating the community members, and also assessed at the pre, post, and 6 months. And during the COVID, we actually conducted a virtual education, and prior to that time, we did in person. So now we change it to hybrid. Next slide. So again, working with the community engagement, we must building the capacity with the community members. So during the COVID time, we actually provided training of how to Zoom and how to online survey, how to conduct a social media campaign. Together, we work with the community leaders and members to implement this effort. Next slide, please. Here again, as there are some highlights of our outreach campaign and through social media, because each ethnic groups have their own social media channels. For example, the Chinese population are using WeChat oftentimes to communicate. So we're using some ethnic channels to communicate. We also conducted the bus campaign. Actually, this is before COVID. Next one, please. Here, I wanted to quickly just to share some results about knowledge improvement. Through this education process, we have actually seen some significant improvement before and after the education. among all these groups in terms of whether Hep B vaccine is the best prevention. You see the yellow line is actually the improvement of knowledge, whether Hep C can be cured, whether baby boomers are the higher risk of liver cancer and Hep C related, etc. Next slide, please. And we also look at other risk factors, not only with hepatitis B and C, but also alcohol, obesity, as well as diabetes. We see the green bars, these are post-education results. So this does not mean they have conducted screening, but at least we began to improve the knowledge of the community. Next slide. So I wanted to conclude this talk just by sharing, and I'm sure all of you are aware of that, the major goals of viral hepatitis National Strategic Plan for 2021 and 2025, which is in line with the work we're doing and trying to prevent new viral hepatitis infection, improve viral hepatitis outcomes, and reduce disparities, and improve surveillance, data usage, especially achieve integrated, coordinated efforts that to address the hepatitis epidemics among all partners and the stakeholders. Next slide. So I wanted to share with you my perspective related to some of the opportunities for eliminating hepatitis health disparities. I think we do need rigorous promotion for hepatitis B vaccination. The screening recommendations and need to be promoted to increase efforts nationally to get high-risk adults for Hep B and C testing, linkage to care. I think all these evidence-based intervention that we have conducted in the controlled trial needs to be implemented at large scale at the population level and in the implementation programmatical trial in the real world, whether it's clinical or community setting, so that could have a higher, larger impact. And I firmly believe community partnership engagement is essential to successful recruitment, retention, and population impact. Expansion of training and education for community health workers and the clinical staff, and how we can work together. Expand hepatitis treatment, access to insurance, and many of our community members do not have insurance. 1/3 of Korean Americans do not have insurance. Over 25% of Chinese, Vietnamese do not have health insurance. So these are the things that will hesitate and to seek care. Integration of public health and clinical care services. We got to expand our work with federal qualified health centers, community clinics throughout the city, and increase our support to address chronic viral hepatitis in the US and globally. And I think there is a lot of opportunities that we can actually eliminate hepatitis disparities by 2030. Thank you.
Thank you, Dr. Ma.